Paroxysmal palpitation. The symptoms of palpitation can be caused by a range of clinical conditions, from the very benign to the potentially life-threatening approach to the patients. With this in mind, it is unusual to see someone during a symptomatic episode. So as much information as possible should be gained from the history, with the main aim being to assess the patient's potential risk. From life-threatening ventricular arrhythmias, you should always have in mind a list of possible causes of palpitation. In most situations, it will be essential to perform investigations during a symptomatic episode. Remember that the severity of the symptoms does not always reflect the seriousness of the underlying problem. Some patients in sinus rhythm may experience severe palpitations, whereas others may be asymptomatic wherein ventricular tachycardia. In this case, the family history should make you particularly keen to exclude significant inherited conditions that may predispose to arrhythmias, that is hypertrophic cardiomyopathy. What are the palpitations like? The characteristics of palpitation can provide valuable clues in making the diagnosis. Questions the patient about the following. Ask her to tap out the rhythm of her palpitation. Note how fast this is and whether it is regular or irregular. Irregular means atrial fibrillation or frequent extrasystoles are most likely a missed beat. Is typically caused by an extrasystole. After the compensatory pause, the next sinus beat is felt with extra force. These missed beats are always of no pathological significance. However, they can cause worry that is likely to be reinforced because anxiety is the most common cause of awareness of extrasystoles. They are likely to have been long-standing and previously asymptomatic. Does she feel the palpitations in the neck? These are suggestive of Cannon waves indicating simultaneous atrial and ventricular contraction. This can occur in atrioventricular block, AV dissociation associated with ventricular tachycardia, or atrioventricular nodal reentry tachycardia. How do the palpitations start? What brings them on and how do they stop? Does she get any warning at all? Do attacks come on gradually or suddenly? Palpitations that come on and go away gradually are most likely due to sinus tachycardia. Are there accompanying symptoms? Does she feel faint or dizzy when these occur? Has she ever collapsed? Arrhythmias causing these symptoms are more likely to be serious and clearly mandate thorough investigation. Some patients with supraventricular tachycardia develop polyuria as a result of atrial stretch, causing the release of atrial natriuretic peptide. How frequent are the palpitations? Palpitations that occur infrequently are likely to be difficult to catch on simple ambulatory monitoring. What treatments have been tried already? A supraventricular tachycardia may be terminated by Valsalva maneuver. Other relevant history. Is there anything to suggest thyrotoxicosis? Smoking, alcohol, tea, or coffee consumption. Acute excess of these can trigger arrhythmia. India is predisposed to it. Drugs. A range of these can cause arrhythmia. Always consult the drug data sheet. Or family history is clearly an important element in this case. Is the patient prone to anxiety? Does she have anxiety attacks? Has she a history of recurrent presentation to doctors and with medically unexplained symptoms? This aspect of the history needs to be explored sensitively. It is unhelpful if the patients think that this line of questioning infers that you do not believe her. If there is a high degree of anxiety, it may be the cause of her symptoms, although other pathological substrates may be present. ECG. In most situations, only a 12-lead ECG in sinus rhythm is available. When assessing the 12-lead ECG of a patient with palpitations, look for sinus bradycardia or tachycardia. Check if there are features suggestive of cardiac structural abnormalities, P mitral or left ventricular hypertrophy. Measure the PR interval. Check if there is AV node. Check the delta waves. Ask the patient if she has had a previous myocardial infarction. Measure the QT interval and calculate the QT correction. Check for any atrial or ventricular extrasystole. However, if an ECG has been recorded during symptoms and documents an arrhythmia, it may not be necessary to investigate further because this alone may enable a precise diagnosis to be made. Test radiograph. This is likely to be normal, although an increased cardiothoracic ratio or abnormal cardiac outline may suggest significant pathology. Echocardiography. This is an important test that helps stratify the patient's risk. If this shows the patient to have a structurally functionally normal heart, it puts her heart into a very low risk group. However, it is important not to discount the possibility of significant arrhythmia just because the echocardiogram is normal, particularly in a patient with potentially significant family history. Abnormal electrolytes, particularly hypokalemia, may predispose to arrhythmias. Hyperthyroidism may cause atrial fibrillation or sinus tachycardia, and hypothyroidism sinus bradycardia. So the blood test, a patient with a normal physical examination, normal ECG and normal echocardiogram is at very low risk of life-threatening arrhythmia. And among the blood tests, there is abnormal electrolytes, particularly hypokalemia, may predispose to arrhythmias. Hyperthyroidism may cause atrial fibrillation or sinus tachycardia, and hypothyroidism sinus bradycardia. Further discussion. In many cases, a benign arrhythmia is detected, such as ventricular atrial ectopy, and occasionally symptoms are clearly associated with sinus rhythm. In most cases, the explanation or positive reassurance to the patient are all that is required. Only in rare instances, where the patient is very debilitated, should a beta blocker be prescribed. Significant symptoms can occasionally be associated with sinus tachycardia. In this circumstance, it is important to exclude causes of sinus tachycardia, the most common being anxiety, before attributing the arrhythmia to inappropriate sinus node function. So there may be palpitations with dizziness. Your main concern is that this patient gives a history of presyncope, which places him in a high risk category for life-threatening arrhythmia. The main objective must be to exclude a significant ventricular arrhythmia with the little information available. It is apparent that the palpitations are directly related to the presyncope, which would be consistent with the diagnosis of ventricular tachycardia. It is vital to ensure that the patient is safe while the diagnosis is established.